And welcome to the Dr. Bob Show. We'll be spending most of this show talking about the great masquerader, a gland in the body that can make you be hyperactive, can make you hot, can make you sweat, can make you lose hair, can make you be nervous, you can't sleep, or it could make you tired. Too poop to pop. I just don't have any energy. Sluggish voice, sluggish all the time, cold all the time, don't feel good, want to sleep a lot. We'll be talking about that gland that's the great masquerader. It's the thyroid gland. My guests, not guests, but two guests are Dr. Bill Law, board certified endocrinologist. He'll be teaching us about that gland and what he does. Second guest, Dr. Mark Overholt, board certified ear, nose, and throat surgeon who does thyroid surgery. They'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about do changes in weather, hot weather or cold weather, affect certain illnesses in the body, like your heart, like your lungs, like your skin? You better bet you they do. We'll be talking about that. You'll want to stay tuned. We're talking with Dr. Bill Law, board certified endocrinologist, and Dr. Mark Overholt, board certified ENT surgeon. We're going to be talking about the great masquerader, the thyroid gland. Bill, welcome to the Dr. Bob Show.
Thank you, Bob.
Mark, welcome to the Dr. Bob Show.
Great to be here.
Bill, tell me about the thyroid. Where's it located?
The thyroid gland is located right here, right below the voice box.
What's
just
it look
in
like?
the very front. Well, I actually happen to have show and tell a model.
Is that all?
This
the
is
thyroid?
actually about normal size for a real person's adult thyroid gland. And it wraps around the airway, the trachea, and right below the voice box. And then the swallowing tube lies in this little groove right behind it. And then the collarbones are about right here. So a lot of very important things all clustered together right there in the lower part of the neck.
Yeah, very, very important. What does that thyroid gland do that's right there in your neck?
It makes a very important hormone called thyroid hormone.
That's pretty simple. I can remember that. Tell me about it. It's not simple, and it's very, very important. What does that thyroid hormone do, Bill?
Thyroid hormone has effects on every tissue in the body. It regulates the synthesis of different proteins. It affects your metabolic rate.
What's metabolic rate?
How fast you burn up calories.
Yeah.
So
it gives you energy?
You need a certain amount of it, or otherwise you don't feel real well.
Is that the purpose of thyroid, really, your body's metabolism with those hormones?
One of many.
And what are some of the other things that it does? One of many.
It can affect your ability to keep your heart rate normal, not too fast, not too slow. It can affect the ability to get rid of fluid, clear fluid, so that you don't get edematous. Can affect your blood sugar levels if you have too much or too little. So it affects everything in the body.
Can it go out of whack?
Frequently. That's what keeps me in business.
Yeah, so it can be abnormal. Does it go abnormal because it just gets diseased and fades away, or it starts putting out too much of the metabolism hormone?
Yes. You can have too much or too little. See, the thyroid is sort of like the three bears in the porridge. You need to have not too much, not too little, just right. And it's very finely tuned. For thyroid hormone replacement, they make 12 sizes of thyroid hormone, far more than any other commercially produced medicine. And some of those are only 10% apart. So it's very finely tuned. It's got to be adjusted just right.
Now there are 12, I can only count to 10.
You need to grow some more fingers.
So is it easy to test to find out how much hormone the body needs?
Yes, it's a very reliable blood test now.
What is the test called?
We measure the free T4, and that's the active thyroid hormone, And then you also have to measure the thyroid stimulating hormone, TSH.
Where does that
because
come
that's
from?
a control center hormone from the pituitary gland in the brain. The system operates in a manner similar to a cruise control on a car. It's a closed loop system. If you're going too slow, you give the car more gas. That's the gas pedal.
So the body regulates it pretty good unless something goes wrong.
Correct.
So it could go wrong up here, but let's talk about what can go wrong here, because we talk about the thyroid gland in itself. What are some of the problems, some of the diseases of the thyroid gland?
Well, you can break them down into hormonal problems and just structure problems. The gland can make too much thyroid hormone, called hyperthyroidism, or it can make too little, which is much more common, called hypo. Hypo means low thyroid. And then you can have the thyroid, regardless of how much hormone it makes, it can grow, it can get enlarged. We call that a goiter. And it can be overall enlarged, or it can just have one or more specific lumps called nodules.
Those nodules, can they become cancerous?
Well, they either are cancer or they're not cancer.
So you can have cancer, you can have overactive, underactive, autoimmune thyroid problems?
Yes, very much.
What's that called?
Hashimoto's disease.
Hashimoto's disease. All right, now, if the thyroid gland can cause all these problems, is the treatment medical or is the treatment surgical?
Yes.
So I take it could be both. So walk me through.
That's where you need a good doctor.
Yeah, and that's where you have to be very, very careful. So tell me, should it be predominantly medical until it's obvious that you need surgery, or they need surgery? Yes.
Well, as a medical doctor, of course it should be medical.
So how do you treat the thyroid gland quickly if it's overactive?
Well, we have medications that can block the formation of thyroid hormone. And then once that's controlled and down in a safe range, if it's an enduring problem, not just a temporary problem, you can destroy the thyroid very safely as an outpatient through the office with a dose of radioactive iodine.
Is that effective?
Very much so. I mean, when they treat President George Bush and Barbara Bush with radioiodine, pretty legit. They don't let Democrats treat Republican presidents.
If you treat the gland with radioactive iodine and destroy the gland, you get rid of it, you have to treat it with medicine. Pretty easy to adjust with those 12 different doses of thyroid medication.
Very straightforward.
And you guide that by your T4 and your TSH. So tell me about if the gland becomes like a goiter, just big. Both sides, one side?
Could be all the gland or just part of the gland. Could be just one lump and everything else normal. Lots of variations there.
What symptoms can it give you? A big...
Just the enlarged thyroid? Most of the time, none until very, very late in the game. Because the thyroid will tend to just to grow out, out in the soft tissue here. And we see people that have thyroid glands this big, look like cantaloupes, and they could eat half a hot dog in one gulp.
Wow.
So if it's down in the upper chest, though, it's hard to grow through bone, and that can cause, pressure on the swallowing tube and on the breathing tube earlier in the game.
And if there is a nodule, how do you find out basically if it's cancer or not? What can you do? You have to get x-rays?
That's always, anytime you get a lump in any part of the body, could be in the breast or the prostate or the lung, the first question you have to ask is, could it be cancer? Now, fortunately for our patients and us, most lumps in the thyroid are not cancerous. Depending on the size, the bigger they are, the less unlikely they are. But a good rule of thumb would be about roughly 1 out of 20 are very low-grade cancers.
Can you find out by doing a biopsy?
Yes, we do very, very simple fine needle biopsies in the office using little 25-gauge needles, which is smaller than what they use to draw blood from the arm with, and they don't even numb the skin up for that.
And that's what we'll be talking about when we come back. What if that nodule turns out to be cancerous? What if that gland is too big, causing pressure? What if the medical doctor decides there's a surgical indication? What does the surgeon do, and what should his training be? We've got a lot of information for you, but first let's look at a patient who had thyroid surgery, and let's see how they did. We're talking with Mindy Williams. Mindy, welcome to the Dr. Bob Show.
Thank you.
What kind of problem? Did you have thyroid problem?
Yes, I did.
What was it?
It was Hashimoto's.
Hashimoto, that's
Yes.
a long name. That's a thyroid problem?
Yes, it is.
What were your symptoms?
I stayed tired all the time. I kept a constant sore throat, and I gained weight.
Was the gland large?
Yes,
Did
very
it
large.
press on your voice box?
Yes.
Did you know something was wrong?
Yes, I did.
When your doctor diagnosed Hashimoto's disease, which is a very, very common problem in women, they told you you would have to have surgery. Who did you go see?
Your son, Dr. Mark Overholt.
Dr. Mark Overholt. How did you like him?
I loved him.
I just think he's a wonderful
Yes.
physician. Tell me, was the surgery difficult on you, and how have you done since the surgery?
I've done pretty good with the surgery.
Does your neck bother you?
No, not at all.
Are you taking thyroid medicine?
Yes, Synthroid.
Take it every day?
Yes.
Are you tired?
No, I've got more energy now.
Is there pressure on your throat?
No.
And so you feel good and you had good results.
Yes.
Mindy, I'm so happy for you. And
Thank
now
you.
you're going to have a little baby, I understand.
Yes.
Congratulations, and congratulations on fixing your thyroid.
Thank you.
We wish you the best of luck.
Thank you so much.
We're talking with Dr. Bill Law, board-certified endocrinologist, and Dr. Mark Overholt, board-certified ear, nose, and throat surgeon. We're talking about the thyroid. It can be overactive, hyperthyroidism, underactive, hypothyroidism, autoimmune problems, nodules, fine needle aspirate, decides if it's cancer or not cancer. Is that a fairly good summary, Bill?
Excellent.
Bill, tell me, you treat medical patients and you treat the thyroid and you diagnose the thyroid. What circumstances lead you to know that you have a condition that needs surgery?
Well, much as it pains me to say it, Bob, as a medical doctor, there are some times where we really need people like Mark over here. There's some things we can't treat medically. Most nodules we cannot make go away. We don't have pixie dust. We can't shrink them with medicine. Rarely can we shrink them with radioiodine. If they get steadily bigger, they can put pressure on the swallowing tube and the breathing tube, uncomfortable, and could even make it be very dangerous if it collapsed the trachea, the airway. And then, of course, there's always the concern about cancer, and many people have quite a few nodules, not just one. And you know, unless you want to have people looking like Yosemite Sam, you can't biopsy all of them. And so sometimes you have to take things out, particularly if you do a biopsy of the big one, the largest one, and it's suspicious for cancer.
Now, Mark, you're an ear, nose, and throat surgeon. What type of qualifications does a throat surgeon need who's doing thyroid surgery?
You need to have good background training in surgery of the head and neck, and most people who do thyroid surgery dabble, and that's not a good thing. The thyroid, as Bill alluded to, is a very complex structure with lots of vital, very important structures around it. And so the American Thyroid Association and endocrinologists who are looking for surgeons who are trained to do surgery look for those people who do a certain number per year. And the American Thyroid Association would like surgeons to do at least 25, and I think the real number is probably a surgeon doing 50 or more per year as a person who does enough thyroid surgery to consider themselves busy, competent, keeping their hands in the surgical field frequently enough that they minimize complications for patients and give them the best outcomes.
You know, a patient really wants to know that. They want to know, okay, how much experience do you have and how good are you? Because sometimes the patient doesn't know. So that training is ultra important. When you think of the thyroid and you think of thyroid surgery, the thyroid's in the neck, what do you think of? I mean, what are your plans for that patient? Do you have to make sure of the diagnosis, or do you trust the internal medicine doctor, the endocrinologist, the specialist?
I think one of the great benefits that a patient has is a team of people who are experts. And so it's my pleasure to have Bill and his colleagues who do a great job seeing patients, medically managing them, understanding, when a patient needs surgery and when a patient doesn't. And we both agree, and there are guidelines that are established that guide us surgically. And so most of the patients that we share are relatively straightforward. They've come through a complex management program, and on the back end have something that guides them towards surgery, either a biopsy, as Bill said, that is indicative of cancer or suggests the possibility, or the thyroid is big enough that it's starting to cause compressive symptoms, leading to swallowing problems or airway difficulty. And so those are the big indications that he's mentioned, and the same ones that I utilize for my patients.
Now, Bill also said just a minute ago, the thyroid's in a very important area. So if somebody is going to cut my neck off, somebody's going to operate on the neck, what are the structures there that you as a surgeon are very careful about?
Well, everybody's concerned with cosmesis. They want to have a pretty incision. Unfortunately, thyroid incisions look good. You can place them in skin creases, and if you close them meticulously, that is an issue that people can kind of put by the wayside. But there are two major potential complications for thyroid surgery. There are two nerves, one on each side, called the recurrent laryngeal nerves, and they provide innervation to the voice box and give the ability of our vocal cords to move and allow us to have speech. And if those nerves get injured in the process of doing a thyroid surgery, then the person's hoarse. And so it's very important that the surgeon who's doing thyroid surgery does a lot, knows the anatomic variations of that type of nerve, and knows how to protect it carefully. The second important structure that lives behind the thyroid are the parathyroid glands, and there typically are four. There are two behind the top pole on each side of the thyroid and two behind the bottom pole. And those produce a very, very important hormone called parathyroid hormone that allows us to regulate the level of calcium in our bloodstream. And if we were to injure all of those parathyroid glands, then the person's calcium level in their bloodstream can dangerously drop, affecting muscle function, heart function, mentation, thoughts, brain function. It's very important.
Wow, so it's getting more and more complicated. Let's talk about that recurrent laryngeal nerve that innervates the voice box. Is it easy to see? Is it right behind the thyroid? Well, tell me about how you find it.
Well, it has a usual anatomic location behind the thyroid gland where you can typically find it. There are some variations. The complication for thyroid surgery is that some glands are very sticky and adherent to the surrounding tissues. Bill mentioned Hashimoto's thyroiditis. Those patients have glands that are typically quite adherent to the surrounding structures, and as you're retracting the gland, trying to find the nerve, you can stretch it and injure it, or if there's a large nodule that wraps around the nerve, then the surgeon could inadvertently injure the nerve. And so that's a really important structure. And when I do thyroid surgery, I like to use a nerve monitor. There's a tube, the breathing tube that we use to put people to sleep. There's a special one that has an electrode array on the tube that allows me to monitor the vocal cord nerve intraoperatively. So I can use a little handheld guide to get real-time feedback as to where the nerve is or if I'm near it. And I think it adds a level of safety for my patients.
What's a nerve look like? And what's an artery look like? Because there's a lot of arteries around. What's the nerve look like?
The recurrent laryngeal nerve is glistening white, and it's probably 2 millimeters wide. It's bigger than the human hair, but it's very, very thin and long and wispy. And an artery typically pulsates. It can be white, but not quite as white as the nerve, and you can see the pulsations in it.
Does the thyroid gland have lots of vascular, a lot of arterial blood goes to it? And the parathyroid, do they have independent arteries that go to it?
Yes, to both of those questions. And that's one of the key things for thyroid surgery is to try to maintain an absolutely bloodless field. So as a surgeon, I'm much safer for my patients as a surgeon and much more proficient if I can maintain an absolutely dry field. And we have great tools today to help us do that. We have a tool called a harmonic scalpel that allows us to seal blood vessels off. And so as the surgery proceeds, it's a virtually bloodless field, and I can see everything. That allows me not to disguise the nerve. I can see it very clearly as I approach it, and it's not hidden in an area where it could be potentially injured if it were under a field of blood.
So when you've done the surgery and you've removed the thyroid gland, How do you close it up? Is that where you get the cosmesis, where it looks pretty?
Yeah, we close it in a couple of layers, and I think probably different surgeons do it differently. I like to close the layers below with absorbable sutures and then put a little layer of glue on the skin. I think it's easier for the patients to manage postoperatively, and it leads to a very pretty incision.
And then after you've taken out the thyroid and the patient is discharged from the hospital, do you follow the patient from then on, or do you?
Well, that's where I love my esteemed colleagues. We share the patient.
So, Bill, no more thyroid, so you're going to do something to help them. What do you do?
I'm going to give them a magic medicine.
And what's that
One
magic?
little pill a day, dirt cheap, $4 a month at Walmart, 0 side effects, presuming the dose is adjusted right, and we're supposed to know how to do that. And let me just add, Mark is far, far too modest. This is very complex anatomy. You realize they call what we do medical practice? Ever thought about the implication of that word? And there's an old saying that practice makes perfect. As endocrinologists, we would like to see our thyroid surgeons doing several hundred thyroid cases a year, because it's like anything else in life. The more you do, the better you get. You learn from your mistakes, no different from life at all. And so we very, very appreciate people like Mark who have made a commitment to becoming expert in thyroid anatomy and surgery, because there's a whole lot of potholes and minefields up here you can fall into.
Bill Law, wonderful medical doctor. Mark Overholt, wonderful surgeon doctor. I'm very proud of both of you in our medical community, because you deliver the kind of care that we like to say all doctors should be doing. Thank you for coming to the Dr. Bob Show. Thank you for teaching to us. It's been a great show. Thank you. Mark, my son, very proud of you. Bill, my friend, very proud of you. Great show. We've just got a little bit of time. I'm going to be talking about different types of weather and how they can affect the heart and the lung and maybe the skin. So a lot of information, and then we'll be talking about the end of the Dr. Bob Show, those 4 things we like to talk about. I want to thank Dr. Mark Overholt and Dr. Bill Law. Wonderful discussion on the medical surgical treatment of thyroid disease. Questions for you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, are there medical problems that get worse in the warm weather versus the cold weather? It's a good question. Is the summer worse than the winter? Is the winter worse than the summer? Let's switch back and forth and let's talk about the heart. In the cold air, if people get out and exercise in cold air causes the skin to blanch, the blood vessels blanch, the adrenal gland will begin to put out a hormone, norepinephrine, to protect the body, and that can make the heart irregular or can cause chest pain. Cold weather with exercise can cause angina. How about warm weather? Well, warm weather in the spring, when we get out in the air and we exercise, it may not be the heart, or I've seen some people try and run through chest pain. If you've got chest pain with exercise, that goes away with rest. See your doctor. It could be the heart. But in the warm months, you may have pollen in the air that causes congestion and sneezing, or causes cough and wheezing in the lungs. Warm air. Cold air is an irritant to the lungs. So cold air can make somebody with asthma have bronchospasm. How about the skin? Well, in the skin, in the winter, the skin gets real dry. The skin can crack. There's an illness called Raynaud's phenomena, and that's where the cold weather makes the blood vessels contract and the skin will become white. So when you warm it up, don't warm it up too fast or it will cause a lot of pain, but it can be warmed up with gentle warming. Not a serious problem. There are people that smoke that have what we call Berger's disease, and cold air that the skin clamps off. They're smokers. You can lose your fingers and lose your toes. So be sure that if you're a smoker and you're having that Raynaud's phenomena, that you see your doctor. Be sure that if you've got warm weather sneezing and wheezing or cold air wheezing, you see your doctor. Make sure that if you've got chest pain, heart pain, pain that goes down the arm, pain that you know is different, pain that doesn't go away, or angina goes away with rest and comes back with exercise, see your doctor. Have an important relationship with your doctor. He'll figure out your symptoms and tell you what to do. All the time we have for this show, remember, are you exercising? Probably the most important thing you could do. Be sure that you exercise 7 days a week. Just get outside. Oh, in the wintertime, exercise. Don't let your husbands watch those football games without sitting on an exercise bicycle, a good Christmas present or season holiday present for somebody. Have them exercise during those ball games. Eat good food, none of that popcorn and fat dip stuff during the ball games. Be sure that you give them fruit, and you can have vegetable dips. You can eat good food. 8 hours of sleep. Don't stay up too late watching those ball games in the winter and in the summer. So get your sleep. You'll feel better. You'll do better. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. I hope you're having a good time laughing. It's so important to you and your health. Find that friend, laugh with them, giggle, make a lot of laughing noise, and you'll stay healthy.